Great. Thank you, Dr. Stork. I think we're going to keep moving, so we're about ready to start the next one. So our final presenters today are Dr. Supreet Deshpande and Candice Johnson. They're going to be presenting on early diagnosis and intervention, which is key to treating complex conditions. Their presentation will highlight a new evaluation for infant and toddlers. Dr. Deshpande is pediatric rehabilitation medicine physician at Gillette and earned her medical degree from Kasturba Medical College in India and her residency at the University of Minnesota. Candice completed her occupational therapy clinical doctorate education at Washington University School of Medicine in St. Louis. She currently serves as rehabilitation therapy supervisor of clinical outcomes, research, and education, and treats patients across the lifespan as an occupational therapist. So take it away, Dr. Deshpande and Candice.
Okay, Andrea, thanks for having us join this meeting today and present our information. Like you said, Candice and I are going to talk about infant and toddler developmental evaluation, early diagnosis, and intervention. I'm going to try to talk fast so I can give Candice more time to do the fun part of the presentation. We have no disclosures. Objectives for today is to talk about the early manifestations of cerebral palsy, understanding evidence regarding early and accurate diagnosis in cerebral palsy, the new screening tools we have, the timelines for when those should be applied, and then we are going to do some case presentations to kind of tie everything in and understand current evidence and opportunities regarding early intervention programs in cerebral palsy. Cerebral palsy, as everyone knows, is the most common physical disability in childhood. It's a group of permanent disorders of the development of movement and posture. It causes activity limitations, and it's attributed to a non-progressive disturbance in the developing fetal or infant brain. The condition itself is non-progressive, but physical manifestations of movement and posture problems can change over time. If there are any other progressive symptoms, then it does warrant investigations into other causes for the changes. CP kids can have other accompanied disturbances like in sensation, perception, cognition, communication, behavior. They do develop secondary musculoskeletal problems, and often epilepsy is a common co-denominator. I would like to draw your attention to the age of diagnosis. Historically has been closer to 24 months of age. The whole concept of early diagnosis, early intervention is not new. It's been talked about since 1889. This is kind of like a pictorial. It actually has gathered more steam since Dr. Novak and her group's clinical practice guidelines that came out in 2017. That has actually led to the AACPDM, the American Academy of Cerebral Palsy and Developmental Medicine, publishing a care pathway, which is sort of the guideline for what we do and when and how. So why early? Historically, we as providers have been a little hesitant to give diagnosis too early. We're worried about, are there going to be changes? How are the parents going to take the diagnosis of your child has a condition that cannot be cured? This is lifelong. There have been a lot of qualitative studies that have been done, and parents actually do want the diagnosis being given earlier. They do want to know what they can do. They go very quickly from being sad to what can I do to help my child. It also helps us harness opportunities for taking into consideration the neuroplasticity. What can we do to help with that? There's also a limited time when children can actually gain selective motor control. It's, I want to say, till 2 years of age. So if we don't work on them earlier, we lose that window for it. We can also start monitoring for musculoskeletal issues early on and hopefully at least delay, if not prevent, the onset of musculoskeletal abnormalities. And of course, optimizing functional outcomes is the main goal. So this is a part of the care pathway. It's a pictorial of what they've come up with. It's really divided into two. Children before 5 months of corrected age and children after 5 months of corrected age. What are the different tests and measures that will help us with the diagnosis? All the ones that have the green bubbles have very strong evidence research-wise to help with our diagnosis. The ones that have the yellow bubbles have weaker strength for research. One of the reasons being it's really hard to catch these kids who are older than 5 months of age, and I'll talk a little bit about why. And therefore, we don't have robust research behind that. So again, the risk factors are again, oops, I'm sorry. The risk factors are again divided into the newborn risk factors and the ones that are after 5 months of age. The newborn detectable risks are, I think of it as children who have had a rough time either during mother's pregnancy or right around birth and perinatally. So any child who needed even a supplemental oxygen in the NICU, not necessarily just even mechanical ventilation, children who are small for gestational age. Neonatal seizures is a big one. They might be term babies doing well for a few hours, but then start having seizures. CNS infections in the neonatal period, genetic conditions diagnosed at birth, hypoxic ischemic encephalopathy. Even if they've had a cooling protocol, they do fall under the newborn detectable risk. Major surgical interventions, so just getting a G-tube wouldn't fall under that, but if someone needed a shunt, it would fall under the major surgical interventions. Drug exposure in utero is a big one. And then, of course, the abnormal head ultrasounds and abnormal imaging. For the infant detectable risk, this is the greater than 5 months corrected age. Again, this is the population that I usually worry more about. They're the walking wounded. They usually kind of fall through the cracks. So a study was done, and Boychuk and them came out with 6 clinical features that are concern enough for prompt referral and diagnosis. So hand preference before 12 months of age, child is fisting past 4 months, does not have head control after 4 months, is unable to sit without support at 9 months of age, consistent asymmetries, and then any complaints of tightness in legs, stiffness between 6 and 12 months of age. They also came up with 2 warning signs if there's a persistent startle or motor reflex beyond 6 months of age, or if there is gait abnormality, toe walking, asymmetric walking beyond 12 months of age. So up until now, till recently at least, we were dependent on having imaging, be it an ultrasound or an MRI, along with our clinical history and neurologic exam to be able to give a diagnosis. And that sort of hindered us because often we did not have imaging available to help us with our diagnostic workup. Now we have the test that Candice will be talking a little bit more about, the general movement assessment, the Hammersmith infant neurologic exam, the DAISY. These are some of the tests and measures that we can use along with the clinical history, the neurologic exam, and in combination with an MRI or ultrasound of the brain. So if we have a good clinical history exam, MRI, GMA, and Hein, the sensitivity and the specificity is very high, about 98%. So again, it's divided into before 5 months, after 5 months. What are the tests and measures? So just remember the GMA and the Hein before 5 months, the Hein and the DAISY after 5 months. Part of why, because we can't do a GMA after 5 months. And again, Candice will talk about that. We are able to give a diagnosis even if we do not have imaging. And so if there is no MRI, less than 5 months, the Hein and DAISY, that's the predictive value of correct diagnosis. And after 5 months, the DAISY and Hein have about the same predictive value. To touch a little bit on neuroimaging, what are the recommendations in the care pathway? So for preterm infants, they recommend that you wait till a term equivalent to get an MRI, and a 3T scanner gives you the best ability to look at subtle lesions. If you really need imaging even before that, it's recommended to use a diffusion weighted imaging, as it can give you a better picture of what's going on. Sequential ultrasounds are what are commonly done because it's so much easier in an infant to do that. They can detect the more involved, the non-ambulatory cerebral palsies, but they could miss the subtle lesions that are commonly associated with higher functioning, for example, diplegics. In the term infants, MRI is recommended kind of within the first week if a child has had encephalopathy or hypoxic ischemic injury. They recommend waiting till about 3 to 5 days because the picture is still somewhat evolving. We want to get a good idea of what the end result of all of that is. Again, if you want an earlier picture, use diffusion weighted imaging. If myelination asymmetry is found on imaging, then it is highly predictive of hemiplegic cerebral palsy. Common things that we see on brain MRIs and cerebral palsy, 56% white matter injuries, be it periventricular leukomalacia, periventricular hemorrhagic infarctions. These are the ones that are generally are diplegics. Cortical and deep gray matter lesions, it's about 18%. It can be basal ganglion thalamus lesions, watershed injuries, multicystic encephalomalacia, or arterial ischemic strokes. Most of these generally end up being our more involved GMFCS 4s and 5s. Brain malformation is about 9%. Generally, these children are also more involved, have more of a propensity for seizure disorders, etc. If the brain MRI is normal in infancy, the parent continues to be concerned or a provider continues to be concerned. It does behoove us to do a full investigational pathway again at age 2, repeat brain MRI, genetic testing, etc., because we may be missing something. We talked a little bit about this. If there is no MRI, then what do we, if it's just not available, parent doesn't want to do one for any reason. I won't read through this whole slide, but we have ways of detecting it, like I said before. Prognosis in cerebral palsy, the recommendation is to hold off on discussing prognosis, topography, kind of tone the child may have, functional level, the GMFCS, at least till around 2 years of age. All of us who work with children with cerebral palsy know that they change, and we also hope that by getting Candice and her team involved early on, that maybe we can make a difference, and a child who looked like a GMFCS 3 maybe ends up being a 2 or so on. So we don't want to give a diagnosis. I will talk to parents. I'll talk about high risk for CP or cerebral palsy itself, and I will tell them, let's hold our horses on adding more adjectives to the cerebral palsy diagnosis till your child is 2, because we really want to see what he or she is going to do by age 2. The American Academy of Pediatrics recommends that primary care physicians take 3 actions simultaneously: initiate a diagnostic workup based on the suspected disorder, refer to a medical specialist to complete that diagnostic evaluation, and refer for early intervention programs and therapies without waiting to have a diagnosis as such. Let's just skip over this. This is just a summary of what we talked about. So we do have a diagnosis now. We have a child we think has cerebral palsy. I think the single most important thing is for either for a clinician, parents, or if you're looking at the child itself, is to have therapies initiated really early, so we can start working and trying to prevent things that can be prevented. So having a strong partnership with our therapy colleagues is very important. We have no dearth for skilled therapists at Gillette. So I'm going to hand it over to Candice, who can talk about the therapy piece of all of this.
All right, thank you. So I'm going to dive a little bit into the role of therapies, and then we're going to look at some cases, and hopefully have some time for questions at the end. I think I saw a hand up earlier. So in therapies, typically what we're trying to support during this time when there's potentially an indication for high risk is doing some of that testing that Dr. Deshpande referenced before, as well as once that testing is complete and there's still a concern, is to be able to initiate intervention as soon as possible. So some of that testing, as was stated, is the general movements assessment, or you'll hear GMA, Hammersmith Infant Neurological Eval, or the Hein, and the developmental assessment of young children, or the DAYC. And I'll talk a little bit more about those here. The GMA and the Hein are getting a lot of attention right now just because of their high predictive value when partnered with other assessments and imaging to look at that diagnosis. So the GMA can be done from birth to 20 weeks of age, while the Hein picks up around 3 months and then can be done up until 2 years of age, or 24 months. And these can be done by, the GMA is a pretty intensive course that you become certified. So you do have to be certified and trained to complete. At Gillette, we have OTs and PTs that are trained in this, and one speech therapist. And then the Hein could be a self-study. There's also national trainers that come around to organizations and also train. We've done both here at Gillette to get our OTs, PTs, and some of our additional providers trained in the Hein to be able to identify these needs as early as we can. The DAYC, excuse me, is a developmental assessment. It's a norm referenced assessment, and it helps us to identify where are they based on age compared peers, and can be used from birth to almost 6 years. It is recommended, if you're using this assessment for this purpose, that it's done twice with about 6 months or more in between, because we want to make sure that at that one day, that one point in time, that delay wasn't due to fatigue, hunger, all sorts of other things. It just helps to strengthen the information that's being provided from that assessment. And recently, a paper was put out by McNamara and colleagues, and they did a scoping review looking at interventions for those from 0 to 2 with motor delay that was non-degenerative and degenerative, as well as just a general motor delay. Here, I just tried to capture, so as related to CP, that would be considered the non-degenerative motor delay. And they looked at all the interventions surrounding that population and what was supported by the evidence and what was not so well supported. And it is interesting, I feel like, as related to what we do, we're looking a lot at CIMT and bimanual training. Currently, it's looking at as if they're both equally valuable and maybe best done when they're both done together. But really, the biggest takeaway is getting in and really focusing on that affected side if we're anticipating it might be more of a hemiplegic CP presentation. We're also looking at making sure that we're increasing our standing programming and when we're starting with that equipment and or just that intervention in physical therapy, as well as how to utilize mobility early in those that we anticipate maybe won't be independent movers, just because of the relationship between movement and cognitive development as a child ages. So I'll talk a little bit more about that in our cases. This is a great article for therapists. I'd highly recommend reading it. It looks at a lot of interventions and does a nice job of having some nice summary tables of the evidence. And it's referenced in the end of this PowerPoint. And so along those lines, when we're looking at a little one that might be at risk for CP, we're really trying to look at what are the indications here. Are we seeing a one-sided affected child or someone that may be more globally affected, and making those interventions specific to those needs. Also, a huge component here with this group and across really the childhood, but very much here with these little ones, is that caregiver support and capacity. This is a time of stress, certainly in the family, and trying to build those parents' feelings of confidence, knowing that they aren't going to harm their child, but that interacting and helping to support them to move and roll and have that engagement is really beneficial. So I'm going to jump into a couple case studies to highlight some of these things that we've talked about. Our first case study, patient was born at 36 weeks, history of HIE. They did receive the cooling protocol, 9 days of intubation, 19 days in the NICU, history of seizures. They have now been connected with birth to 3, seen by PM&R and neurology. And so when we got them in therapies, we got them at about 5 weeks, which was fantastic because it allowed us to do the GMA as well as he aged, do the Hein. And so we're going to look here at some of his results. So this first one, what I'm going to actually do is maybe I'll do the typical first and then we'll take a look at him. But in the GMA, on the 0 to 8 week time frame, you're looking for what's called general movements. And so babies can have typical general movements. They can have a poor repertoire or kind of a decrease frequency and spontaneity of those general movements, or they could even be chaotic where they're more what we might think of as like spastic movements. And so we're looking for all those things when we're doing a GMA. So this little 8-weeker, this is what a typical GMA would look like. Let me know if the video is not playing on your end. He starts a little slow. So what we're looking for, is it playing?
Yep.
Perfect. What we're looking for here is that nice variety of movement. I don't want to be able to mimic what the child is doing. I want it to be spontaneous. The trainers refer to it as almost dance-like, a lot of variability. We want to see all limbs involved, some trunk movement, some neck movement, some head movement. So that's what this baby is demonstrating for us so nicely. Stop him and we'll look at our case friend. So with this friend, what we noticed and what you're probably seeing is just a decrease in the amount of movements. When we do these videos, we want the baby to be in a calm state. We don't want them to be crying. Ideally, we don't want them to be too sleepy. So it's kind of that perfect state, which is hard to come by. So often we'll have parents help us by doing a video at home and sending it in. But we need only about 3 minutes to really see some things that we want to see and have a pretty good indication of where they fall. But we do like to do, so with this being that he was 5 weeks of age, we'll see on the next slide, we did recommend that he come back and have more videos. So we actually have 4 GMAs on him to make sure that what we saw at 5 weeks was either consistent across or that those things changed and he ultimately had exhibits of the general movements. So after about that 8 to 10 week period of age, it moves from the general movements into what we would call fidgety or absent fidgety or abnormal fidgety. There's 3 different options. But how I would describe fidgety is it's kind of like those little tiny movements that we wouldn't even notice on a baby where it can happen in all your joints. I can't show you my legs, but it would be happening in the leg joints as well, hip joints, knee joints, ankle joints. And we'd want to see that across all limbs, again, with variability. So we'll take a look at what that looks like. So with him, you can see a couple in his shoulders, some in his wrists, some in his hips, a little bit in the head. Again, the course for training for this is 3.5 days. We watch videos after videos of many cute babies. And at the end, you have to pass a test to be able to be certified where you are indicating all of these movements on different babies. So it does take a bit to kind of have a trained eye for what you're looking for. What's nice at Gillette is we have about 20 therapists that are trained. So if we have any question, we send it out to the team looks at it together, and we come to consensus on what we think we're seeing. And we have a pretty high inter-rater reliability at this point. All right, we'll take a look at our case friend. So his kicking movements wouldn't be considered fidgety. They would be considered more of just a reciprocal kick movement, but it's not the small little fidgets that we want to see. So you'll kind of see his wrists and ankles are pretty stable. The neck and head is pretty stable. At this point, those big movements should be there, but there should also be the little fidgets in the joints as well. So then, because he was showing some indications on the GMA, we continued to see him for intervention. And at about 9 months, he completed the Hein, which is an assessment that looks at multiple areas of development neurologically. And there are optimality scores as well as cutoff scores that have been shown to be highly predictive of a later CP diagnosis. And so he scored a 38, and you can get half points in different things. So that's why it's a 38.3 out of 78. And so if you look down at the 9 months, the cutoff score, we would want to see something 62 or above to be in the green, likely no CP area. So again, he's showing indication for potential future diagnosis there. So what did physical therapy do with that? They looked at strategies for positioning, gross motor skills, midline movement, cervical range of motion, head and trunk control, and overall strength for increased engagement in developmental play and movement. They did a lot of parent education. These parents are very engaged and have done a nice job of carrying over these skills into the home environment, which has been wonderful for this patient. I'm going to show just a little video of some home programming. So here he's at home. Mom was trained in how to facilitate some rolling. I don't think the audio is on this video, but they're cheering. They're pretty excited for him, which is awesome to see. And at 11 months, he was progressing to working on a little bit more decreased support when sitting, as well as continued work on 4-point to help with that strength in the shoulder girdle, the hips, and ideally facilitate some movement in the future. So OT and PT were also pulled into this case due to the fact that he is demonstrating some needs more globally. And so they looked at the areas of feeding right away. Early, he was having some challenges with bottling, with his suck swallow. And so they were engaged in the plan as related to feeding. And then OT also looked at some early development, use of the hands, developmental positioning and play, and rolled him out for that. His feeding plan, was seen for a swallow study. They found that he was aspirating, and so he began NMES, which is where there are electrodes that help facilitate the swallow muscles and help to hopefully strengthen and coordinate and help learn how to more effectively swallow. And due to his presentation of kind of bilateral involvement, we did not initiate any CIMT or anything like that for this little guy. And I don't know if you can hear the audio, but this is just some engagement in some of the feeding therapy with NMES. And again, I don't know if you can hear the audio, but she just referenced the spoon that she's using is vibrating to help increase some of that input, to help initiate more of a lip closure, and then that management of the food bolus and bringing it back for that swallow. All right. I'm going to move to our next case to kind of look at a little bit of a different presentation. This patient came to us actually through our brachial plexus clinic. There was thought that he maybe had a brachial plexus injury. However, it was determined when he got to that clinic that it likely was not a brachial plexus injury, and some further assessment was completed. Once that was done, it was determined that he likely was more presenting as CP hemiplegia. And so once he came here, he met with neurology. He also got connected that same day as a partner with our brachial plexus clinic. Our OTs are in that clinic. So he did see an OT for an evaluation and completed the evaluation consistent with what we would do for our patients with brachial plexus that day. And then was rolled out for therapy for OT, and then also identified that PT would be beneficial, was referred and scheduled for that, received some imaging, got scheduled with PM&R, and then as he continued to receive care, got referred to speech therapy due to communication delays. So for occupational therapy, when he came to us, the Bailey and the DACY were completed. The DACY was completed a little bit later in his plan of care, just due to the fact that we were unclear on his reason for coming. And once we determined it was more developmentally and potentially CP based, we pulled that in. We also looked at range of motion and arm movement, and then just general play. PT completed the modified Ashworth scale. They looked at the Hein, where he scored a 64.5 out of 78 with 8 asymmetries. A nice thing about the Hein is throughout the scoring of the Hein, on every item, you indicate if there was any sort of asymmetry. So did one side do it, the other side didn't? Was the quality different? Was there anything that just looked where it was asymmetrical? And there is current research that indicates if you're getting about between 4 or 5 asymmetries, it is highly predictive of a hemiplegic presentation. This friend had 8 asymmetries. Receptive and expressive language through the DACY, and as well as looked at a complete dysphagia evaluation to ensure there was no dysphagia concerns. And at that time there was not, and he continued with a typical diet. So all of our therapies throughout his plan of care really looked at kind of coordinating what he needed as well as not overwhelming the family. Family is a non-English speaking family, and mom and dad had some disagreements on how much therapies, when to complete therapies, what was the best therapy option. And this was also due to the fact that because he came to us at about 8 months, where developmentally there's a lot more stranger danger and apprehension by the child to see new providers, he was crying quite a bit throughout our sessions. One of our early goals for therapies was truly just tolerance to a session. So we typically schedule for an hour session at a time. We were having a goal of, could he make it 30 minutes before we needed to discontinue and give him a break, and kind of work that up. He now is 39 months. You'll see some videos. He's tolerating full sessions. He's doing very well, but that took quite a bit of time to get there. And then with those sessions, we were all looking at really task-specific training, making sure that we were having games and toys and activities that he was really motivated to engage in, things that he was able to have fun with. PT really started looking at standing and mobility right away. They also identified a potential need for orthotics, which was ultimately recommended and fit at about 14 months. He also utilized the gait trainer, and we worked to get him one for home. A good and kind of not a bad thing, but we did ultimately get that approved and got sent. However, the patient was able to be walking independently about the same time that he got the gait trainer. So it was utilized to help increase speed of gait and continue working on that goal, but he now is more of an independent ambulator, as you'll see here. So he's affected on the left side, as you can probably tell. And he continues to work with PT on management of kind of positioning, some bracing, looking at stairs, balance, and overall function. And then for OT, because of some of the things I shared about his tolerance and just kind of the understanding of our care planning and what was able to be tolerated as well as carried over in the home, CIMT with constraint was completed. However, I would say it was not textbook by any means. We definitely utilized those principles in session of providing him great postural support and using a mitt on the strong hand to increase engagement of the left hand. However, we had to really modify the amount of time that was utilized based on his tolerance of it. We also sent that home with mom to be utilized at home with further education on daily goals for timed use. We also talked about he's a smart kiddo and he can typically pull off most things or get out of most things. And so we've also talked about actually casting at this point. We have not done that yet, but anticipating that likely will be something that we'll do in the future. He has began, and I'll show some videos here at the end, to utilize his left hand more independently or with pretty minimal cueing because of really intensive bimanual training. We've spent most of our sessions utilizing toys that require two hands for function and really tried to engage him in the tasks that he enjoys and doing them over and over and over again with that use of the left hand. We are also at a place, typically when you're going to cast someone, you want the child to have a level of grasp because it really does affect everything they do, how they feed themselves. Can they grab food? Can they open a door? Can they, get out of a shirt? Those types of things. He is indicating kind of some mirroring movements for grasp. When he squeezes the right hand, that left hand will follow. And he can independently open, but he isn't showing very controlled grasp to hold items unless he's holding something in that right hand. So we're really working on that grasp open and close with him in hopes that we can get a bit more function prior to looking at something like casting. So we've also looked at his level of independence in the areas of feeding and dressing. We did quite a bit of work and education around sleep for him as well, just to help with the schedule, help parents to feel like they were getting the rest they needed to be helpful for him throughout the day. Certainly the main focus has been play, and then he has done some orthotic wear. He started with when he was very little, a McKee splint that just goes on the thumb and wraps around the hand to just pull that thumb out of hand so he's not fisted. Then we moved to a small Benic orthotic, which is like a neoprene style that did the same thing. And then now he has a custom wrist, hand, finger orthotic that he wears at night. So that puts him in a functional position so that he isn't fisting throughout the night. And he's tolerated that well. So just looking at a little bit of a comparison, this is him at the beginning of the summer and then here at the end, and how he's utilizing that left hand. So as you can see, the main goal for us as a therapist is really for him to initiate that movement on his own. We don't want to be doing the hand over hand to make him do things. But when they have very limited function, that becomes harder. So you can tell she tried to really back off that support when he started to initiate that reach and that opening of the hand to push the coin in, which is great. So this day was super exciting. It was one of the first times that he really used that left hand without any even like hand on top of the right or just small cue to not use the right. He was able to do it just with the presentation of the toy on the left side, which is awesome. And he's demonstrating that nice open hand and some nice reaching. And then with him at the same time, he's been seeing PT, OT, and speech for quite some time together. Excuse me, not at the same time together, but having appointments each week in each discipline. So in speech, he's been looking more at joint attention, turn taking, some system for communication. So he currently has very few verbal words. And so he is utilizing some pictures, some pointing, just more of a Velcro board, low tech speech device at this time as he's continuing to learn where he will go and be with his communication. He did start school this year, which I think he's been in it for about 5 weeks, and it has been very beneficial for him. And so we're starting to hear a little bit more from him, as well as just seeing more independence. He's coming back with the therapist on his own without mom, showing some nice ability and independence as he's continued to have those opportunities in the community as well. So in summary, this is just a slide of our risk factors, just as a reminder of little ones that might be beneficial to see for this infant and toddler developmental evaluation, just to see if there's anything else that we can help with supporting in their development. And typically what would happen when the patient is referred to Gillette, they'll be seen by either PM&R and or neurology, and then referred as appropriate to therapies. However, if they come in through the therapies door first, if we get a referral to therapies and we identify that there's a concern, we will go backwards. We'll request that they are seen by our PM&R or neurology team to ensure that all of the assessment is being done to make sure that we're looking at them globally. And then from there, we will continue to collaborate with Birth to 3 programming, schools, the primary provider, to make sure that they're getting some nice collaboration as they continue to grow. And then these last slides are just, I think, information you guys have seen in the chat throughout today, but just how to make a referral and how to contact us. That is what we have. Thanks, you guys.